Okay, welcome to the second part of the rapid reviews. Okay, you ready? Okay, so we're gonna go to the okay. You don't mind your voice being in the video and stuff, right? Okay, sounds good. So let's do this. Now we have a middle-aged gentleman with HIV and hypertension and hyperlipidemia. What's the risk factor for atherosclerotic disease?
Oh, HIV.
Yeah, so excellent. So this is HIV. Just I want you to be aware that increases because it's an inflammatory state. Any inflammatory state in the body increases for coronary artery disease, because coronary artery disease is basically inflammation in the endothelial vessels that trigger atherosclerosis and heart attack. So HIV, rheumatoid arthritis, all these things they like to ask about. Okay, middle-aged woman that came in with 6-week history of chest pressure that increases with exertion, relieved with rest. Okay, what does that tell you? Normal EKG. What do you do? The best next step?
That's unstable, so you should just trust. It's unstable, so you should probably do a EKG and then stress test.
Yeah, stress testing. You know, it's chest pain. No, it could be stable. The unstable when you have chest pain with rest. Okay. When you have chest pain with rest, this is called unstable angina. But this is a stable angina, typical. Chest pressure increase with exertion. Exertion. This one. Okay.
So you said it's unstable, right?
No, it is a stable angina because it increases with exertion and relieved with rest. But if you have chest pain even at rest, then that's called unstable. Okay? You got it?
Oh, okay.
Yeah, and then because the EKG is normal, then we do exercise electrocardiography. Exercise EKG. The other questions, they just said EKG is abnormal. Or they give you EKG that is abnormal. Then you do exercise echocardiography. See the difference, how they can change it?
Yeah.
So that's why you gotta pay attention to the high yield clues. Now we have a old man with heart failure worsening dyspnea. Okay. EF 20% showed CVP of 9 and paradoxical split of S2 and S3. Okay. Medications have aspirin, enalapril, isosorbate dinitrate, and furosemide. This is very important. You know, GDMT for heart failure. So they tell you what is the patient missing from the GDMT? What is the thing that you need to add?
So acidic nitrate, furosemide, yeah, they have to give it carvedilol.
Carvedilol. Why? Because it has mortality benefit. Okay, it's called, I think, the MERIT trial that showed carvedilol decreases mortality, and the enalapril has mortality benefit. Emdur and hydralazine has some mortality benefit. Okay. Lasix doesn't, but has symptomatic benefit. And okay.
Yeah, this is very high yield, right?
Yeah, it's very important. Okay, so you have an old woman with progressive fatigue, orthopnea, and peripheral edema. Okay. Shows grade 2 hollow systolic murmur on the left lower sternal border that increases in intensity during inspiration. Right heart cath demonstrate diastolic equalization of pressure, and simultaneous right and left ventricular hemodynamic demonstrate concordant rise and fall of systolic pressure with respiration. Okay. Echo showed left ventricular wall thickness of 11 mm. Primary. So what is your diagnosis for this patient?
Cardiomyopathy?
Yeah, whenever you see this clue, concordant rise and fall of systolic pressure with respiration, and left ventricular wall thickness of this, I included more in this question because they could bring any of those clues. Okay, when they say that diastolic equalization of pressure. Okay, this is a primary restrictive cardiomyopathy. Sounds fun? Okay, let's go. So now we have the elderly woman who came in the ED after 4 hours of abrupt onset, sharp tearing chest pain and a back pain. CT angiography shows descending thoracic aortic aneurysm, okay, and maximal diameter of 6.8, and the aortic dissection originating distal to the left subclavian artery and extending just below the diaphragm, but no involvement in renal artery. So this is a pretty huge dissection, right?
Yeah.
You see,
yeah.
it start. Okay, this one should be a different color. The green, I'd like to keep the huh?
So there's the aneurysm and the dissection. Okay.
Yeah, aneurysm with the dissection from distal to the subclavian to the diaphragm. Okay. So now they're asking, you know, the way we study is ascending or descending, and just decide the treatment. Okay. So if it's descending, how do you treat it? And if it's ascending, how do you treat it?
So if it's ascending, you do surgery right away. First off, you should
this is descending.
This is descending, so you just give blood. You control the blood pressure. You give methadone.
Yeah, excellent. Medical therapy, okay. And because you see, it's descending, extending to the below the diaphragm. You know, so this is gotta be. You see, that's why you gotta. So why medical therapy, not surgery? That's a good question, because the aorta, the descending aorta, has so many blood supplies, so many organs, and if you do surgery, the risk outweigh the benefit. Okay, so.
Oh, that's interesting. I didn't know that.
Okay, so they could mess things really bad, but the ascending may be better too. Okay.
You never do surgery, right?
Huh?
Okay, no, don't worry. You never do surgery, right?
Yeah, I do medical therapy. Okay, including beta blocker, sodium nitroprusside, and opioid. Okay, this is kind of the medical therapy. Okay, now we have an elderly gentleman with 1-day history of worsening dyspnea and 1 month of an increasing weight and peripheral edema. Okay. Now, chest radiograph shows enlarged cardiac silhouette and prominent pulmonary vasculature and evidence of pulmonary edema, and echo showed cardiac tamponade. Okay, so they give you the diagnosis. Okay, pulsus paradoxus of 16. What does that tell you? What did I tell you? Like whenever you see blah 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 blah, pulsus paradoxus 16. What is the diagnosis for just pulsus paradoxus 16? It's tamponade. They just gave us the diagnosis as well. Now, this is not the question. So, and they give you even Beck triad, JVD, hypotension, and tachycardia. This you got to be aware of. Okay, these are Beck's triad. How do you treat that patient? So they ask about the treatment. So they literally just give you the diagnosis. They could have just summarized this question, just tell you, oh, how do you treat pericardial tamponade? How do you treat it?
Like pericardial census.
Yeah, drain it, relieve the pressure. Okay. Now we have middle-aged lady that have anastemia 3 weeks ago, and she was given anastemia. What do you give medication to anastemia?
Yeah, two antiplatelet, beta blocker, statin, and anticoag.
Yeah, it looks like she had HFrEF as well, so that's why they added these and metoprolol. And usually, if the heart rate a little bit high, tolerate the metoprolol. And then the idea she developed dyspnea. Okay, so dyspnea is a side effect to ticagrelor, just something to keep in mind. Okay, if they ask you someone have dyspnea after ticagrelor, this is ticagrelor, common side effect of ticagrelor. Okay.
Okay.
Now we have a lady that have acute onset dyspnea, palpitation, chest pain. Okay, happened shortly after her dog attacked by another dog, and then EKG shows anterior hyperacute T-wave inversion suggestive of ST elevation myocardial infarction. This is the question that you were asking me about. Okay, she had some sort of a trauma. Let's say, okay, depends. It's trauma to some people. And then she had a STEMI with normal coronary artery. What do you call that?
Oh, that's Takasupo.
Yeah.
You don't know nothing for it.
Yeah, this is Takasupo. They have chest heart attack, symptoms with ST segment elevation, takasol. Okay. So now we have.
Is there a specific EKG for it, or
no. That's the idea. Just like there's ST segment elevation and normal heart cath. That's it. Okay, and there's some sort of a trauma. Okay. So, middle-aged lady that have recent onset exertional dyspnea, that is, okay, and S1 is normal, S2 is soft, and there is a grade 4 late peaking systolic murmur at the left sternal border. What does that tell you?
Systolic murmur heard at the left sternal border. Wait, don't say it.
And I'm going to give you more features.
It should be prolapse.
No, so let's see, okay? Late peaking systolic murmur at the end of the left sternal border and second left intercostal space, okay? Now, also there's ejection click, okay? And echo showed pulmonary valve stenosis, okay? So they gave us the diagnosis, and peak systolic gradient of 65, okay, with a mean systolic gradient of 50. And pulmonary regurg is present as well, okay? So any systolic murmur usually either could be aortic stenosis, pulmonary stenosis, or mitral regurg. So this patient have pulmonary stenosis and pulmonary regurg as well, okay? So the idea, what do you do? How do you treat that patient?
Oh, you have to. Because you cannot do valve replacement, so you should balloon.
Yeah. So this is severe symptomatic pulmonary valve stenosis. She has a lot of symptoms: recent exertional dyspnea, and then she had some bad pulmonary artery, and then the systolic gradient of 65. Okay. The peak systolic gradient of 65, okay, and mean systolic gradient of 50. This indicates like severity. It's very severe. Sometimes even they don't give you the numbers. They just tell you severe pulmonary artery stenosis, pulmonary valve stenosis, not artery. So you need to do balloon for this patient. Now we have a middle-aged gentleman, 60-year-old gentleman, with 2-day history of intermittent chest pain, dyspnea, and exertion, okay? Medical history of COPD, limited by COPD. Anyway, there's expiratory wheezing, distant heart sound, and echo showed left ventricular hypertrophy. So whenever there's expiratory wheezing and some sort of dyspnea, shortness of breath, and he has COPD, what do you think could be causing that? And there's a left ventricular hypertrophy. So what would be your best next step for this patient?
Angio. Wait, why is angio?
That's a good question. The reason for that, because this patient, you see, has a lot of comorbidities, okay?
Yeah.
And COPD, okay? So this patient, that what he's having, 2 days of chest pain, dyspnea and exertion, they make us think it could be coronary artery disease, could be angina, okay? There's a blocked artery that causing his symptoms, 90% stenosis or something, and they're giving the COPD comorbidities, and then left ventricular hypertrophy on echo will probably gonna have an abnormal EKG, and sometimes they give you EKG is gonna be abnormal as well. So the echo is not helpful, wouldn't be as accurate. EKG is abnormal, so just go straight to coronary artery angiography, because these high-risk patients, just do the heart cath. They probably have some sort of stenosis, okay? Now we have young lady with chest discomfort, lightheadedness, and low heart rate, okay? The discomfort is sharp and worsened with inspiration, okay? So this patient have sinus bradycardia that causing her to have symptoms. So what would be your best next step for this kind of patients?
Low heart rate. Okay. So the heart rate is all that worsening. Oh. Okay.
So you do exercise treadmill stress testing. Is that patient with sinus bradycardia? Do you do exercise testing to assess for chronotropic incompetence and suitability for pacemaker? They probably need pacemaker. Okay, so if you see pacemaker or exercise treadmill stress testing for these kinds of patients, whenever you have like sudden palpitations and arrhythmia, okay, lightheadedness, low heart rate, they probably have some sort of arrhythmia that needs some sort of pacemaker. So that's kind of just to keep in mind, okay?
Yeah.
And now we have this pregnant lady that have high blood pressure of 166 in both arms, and showed average blood pressure is too much. Like you see, so she's hypertension, okay? So now the question is basically asking you, how do you treat hypertension in a pregnant lady? What's the best medication, huh?
Labetalol, hydralazine, and one more.
Okay. Yeah, labetalol, hydralazine. These are safer. Like try to avoid lisinopril, and lisinopril will cause some renal issues, and just try to stay away from these other medications. Okay. And this is the end of the section.